The first priority is determining whether the child has signs of airway compromise. Assessment should include respiratory effort, oxygenation, mental status, hydration status, and the presence of stridor. So important red flags include stridor, rest, cyanosis, severe chest retractions, tripod positioning, drooling, difficulty swallowing, decreased level of consciousness, toxic appearance, or poor air movement. The diagnosis of croup is primary clinical, so a focused history should include symptom onset, progression, fever, cough characteristics, nighttime worsening, previous episodes, immunization status, and possible foreign body exposure. The physical examination should assess the severity of airway obstruction and respiratory distress. Severity classification guides the management. So mild croup typically presents with barking, cough without stridor at rest, and minimal respiratory distress. Management includes a single dose of corticosteroid, supportive care, hydration, and caregiver education. Moderate croup includes persistent stridor at rest, increased work of breathing and retractions. These patients require corticosteroid therapy and closer monitoring. Nebulized epinephrine may be considered depending on severity. Severe croup includes marked respiratory distress, significant retractions, decreased air movement, fatigue, hypoxia, or altered mental status. So these children require urgent treatment with corticosteroids, nebulized epinephrine, and continuous monitoring, and possible emergency transfer. So routine diagnostic imaging and laboratory testing are not usually required because croup is diagnosed clinically. So imaging should be reserved for those cases where alternative diagnoses are suspected, such as foreign body aspiration, bacterial tracheolitis, or epiglottitis, or airway abnormalities. Disposition depends on clinical response. Children may be discharged when symptoms improve, oxygenation is stable, and caregivers understand home care instructions, and also reliable follow-up is available. Hospital admission or transfer is required for persistent respiratory distress, recurrent symptoms after treatment, need for repeated epinephrine treatment, hypoxia, dehydration, or concern for airway compromise.